Hello, I'm Dr. Nancy Kuntz, a child neurologist at Ann and Robert H. Lurie Children's Hospital in Chicago, Northwestern University.
And I'm Sam McKenzie. I'm a physician scientist, child neurologist with specialty in neuromuscular medicine at the University of Rochester.
And today we'd like to talk about management of serious adverse events in gene therapy for Duchenne muscular dystrophy. Sam, this is something that I think in the last several years has been quite interesting and also highlighted the need for many of us who've been in practice many years to go back to the basics and really study the organ reactions to a lot of these new drugs, because most of the children tolerate these therapies very well, but when they don't, it really requires a lot of basic physiology knowledge, as well as involving our colleagues from other specialties to really help us and make sure that the children do very well.
I would absolutely agree. It's wonderful that we have some of these emerging treatments available to us, but I think it's always a sensible idea to, as you said, go back to the basics and understand what some of the side effects may be. And certainly we're getting more experience with those side effects, and we're going to be talking about those today.
Yeah. Sometimes it's hard to discipline yourself to remember that we have to look to the very beginning, and even at the time of dosing, there is a very small potential for initial systemic reaction or even anaphylaxis with any new drug. And again, thankfully, this has been very, very rare, but this is why the dosing, I think, appropriately occurs in a hospital setting with a lot of backup.
Yes, agreed. I think this is a perfect example of why gene therapy really requires a experienced team, and that we take this very seriously and recommend that it be administered at centers with experience using these medications.
One thing that I always prepare our team for is to pay attention to the time of dosing, because there is a potential for either a systemic reaction with itching or paresthesias or minor symptoms, all the way to a full anaphylactic reaction. And that's why it's very appropriate to have gene therapy be administered in a hospital setting with protocols in place for any of those occurrences. It's also why many of us will treat children with small degrees of medication in advance. For example, many sites, including mine, will treat children with acetaminophen, diphenhydramine, and ondansetron, just to minimize their reaction to that immediate therapy.
Absolutely, Nancy, and I think that really underscores, as you said, the need to have a multidisciplinary team that's has experience with infused medications. And while anaphylaxis is rare, it can happen with delandistrogene moxeparvovec.
Mm-hmm. And then one of the not very serious but very pervasive side effects tends to be just nausea and vomiting. I've seen estimates of 80 to 90% of all children having some degree of nausea or vomiting within the first 48 hours after gene therapy. And that usually responds very, very well to just symptomatic treatment, either with oral fluids or with some additional doses of ondansetron. On the other hand, these are children who are on very high-dose steroids, and we have to be very poised and aware that if they don't get their steroid doses done orally, if they're vomiting so much, that we may need to give them, IM or intravenous steroid supplements to make sure that they're okay, and assess to make sure that they don't need any stress dosing of their steroids in that setting.
Also agree on that point. It's something that we've observed fairly frequently, and this was certainly borne out in the clinical trials. We really prepare parents for the likelihood that there will be some nausea and vomiting after the infusion, and in many cases will prescribe ondansetron for at least the first few days, sort of prophylactically.
Mm. And then the children, in my experience, tend to do relatively well, although there is a blip, an occurrence of some immune reactions within the first week that can be an inflammatory or immune reaction to the dosing with the viral vectors and the transgene. And myocarditis can be part of that initial first week response with complement also sometimes causing low platelets. So again, from the very beginning, careful monitoring needs to be done.
Yes. So in my mind, I sort of compartmentalize the more serious potential adverse events as a cardiac and a hepatic, which I know we're going to get to. And that cardiac involvement can be seen in those first 1 to 4 weeks after infusion typically, which is why it's really imperative that we follow troponin levels and are really checking in with our patients to make sure that they're not showing any physical symptoms that would suggest myocarditis.
Well, one of the surprising things for me as a neurologist is that sometimes myocarditis can present with vomiting. So not just in the first 48 hours, but recurrent vomiting within that first 1 to 4 week period has, in a few children who've been observed, been the first sign of a myocarditis. So it's always very important to, carefully evaluate and preferably get eyes on the children, and then, as you mentioned, do those safety labs to make certain that it's nothing other than just a little bit of stomach upset.
Yes, and to round out that assessment, as you said, we'll do the physical exam, but also try to get an echocardiogram and EKG if there's even a hint of concern for myocarditis. In some cases, I know centers have performed cardiac MRI. There are other labs that we want to look at in terms of complement levels, C3 and C4, total complement. We recheck CKMB with the total CK. We perform urinalysis, cystatin C, inflammatory markers like C-reactive protein. So it's really a lot, and we take it seriously. But it's certainly an adverse event that we don't want to miss. While we haven't seen any fatalities due to cardiac involvement with delandistrogene moxeparvovec, it certainly has been seen in other gene therapies. So I think it's imperative that we're vigilant.
And I think a very important time to have your colleagues in cardiology, preferably ones who know Duchenne very well, but who also know that child, follow you through those weeks, hoping that they're not needed, right? And then I think there tends to be this very brief lull where the children do well, but then at the 4 to 8 week period, kind of sometimes more the 6 to 8 week period after dosing, is a time when transaminases tend to be evaluated in a response from the liver.
Yes, absolutely. So that's where we are thinking about, the effects of the vector or the transgene causing that sort of liver inflammation that manifests as increased AST and ALT. I know you share my affinity for avoiding the term liver enzymes, but in this case, they probably are liver enzymes if they're elevated. And we also know that corticosteroids can have impacts on the liver. So it can be hard to tease out what's due to the gene therapy versus the high-dose corticosteroids themselves.
But it does also emphasize the benefit of considering getting GGTs as well, because there have been cases of immune myositis where the CK and the transaminases go up. And GGT can help you a little bit there, make a differentiation between the liver and the muscle, again, as the target organ for the immune response.
Yes, I completely agree. And I certainly check AST, ALT with the GGT. I've almost put more stock in the GGT when we're monitoring liver involvement.
Well, I think many of us will find that the first appropriate step, if we're seeing changes in the transaminases or the CK or the troponin, would be to increase the dose of oral steroid, to take the supplemental oral corticosteroids that were at 1 milligram per kilogram per day and increase it to 1.5 or 2 milligrams per kilogram per day. But I think that increasingly, as we see the rare child that has a significant reaction, I'm finding myself more inclined to give supplemental steroids beyond the additional 1 per kilo orally as an IV methylprednisolone bolus.
Yes, I share that. I think we are in, I don't want to say an evidence-free zone, but we're certainly learning about this medication as we use it in the real world. And I think it's absolutely appropriate to kind of think about a stepwise treatment plan that includes increased oral supplemental steroids, moving then to an IV methylprednisolone, where you also have the benefit of monitoring these patients in the hospital. And in rare cases, IVIG has been used to mitigate some of these adverse events.
Right. And I think that working with this kind of reaction with the liver transaminases up at the point when you begin requiring additional supplemental steroids is a very perfect time to make certain that your local hepatologist, someone who's very familiar with hepatic reactions to drugs, but who also might be a liver transplant expert, is available to give advice about management.
Yes, and this is a call to arms for all of our pediatric hepatology colleagues. If you have an interest in gene therapy, we would love to bring you into the fold.
Absolutely. Absolutely. So to date, the overwhelming majority of children who have this kind of reaction do respond to the supplemental steroids and monitored carefully, sometimes in the hospital with the IV boluses of steroids, the IVIG, monitoring carefully to make certain that they don't have any coagulopathy. But certainly if the coagulation profiles, the synthetic function of the liver, or the bilirubin tends to start changing, that's when you really want to be hand in glove with the hepatology team to really get their very expert advice about how to manage that. I know that to date there has been no child who's had a liver transplant due to very severe reaction to delandistrogene or any other gene therapy dosing that I'm aware of. But I think that that's the kind of thing that we need to keep our minds open to and discuss with our hepatology colleagues.